Preeclampsia. My most important thing is be vigilant, because Louise talked before about the whole basis of antenatal care. It was really, people marched in the 30s, I think in 20s and 30s in Scotland, to allow women to be seen antenatally in hospital, because women were dying at home fitting very unexpectedly. And the whole base of antenatal care has really been around taking blood pressure, urinalysis, fetal growth. So these things are very important, and if we see any concerns about those, then we should be vigilant, because Louise has said somebody can be going along really not too bad, a bit of chronic hypertension, suddenly get very, very sick. So this is unfortunately a recent case. I am one of the people that audit the stillbirths in our trust, and again the name's changed, but this was a 21-year-old girl in her first pregnancy. Her mother had had preeclampsia. She had been diagnosed as being low risk, but no other risk factors. She was a thin girl. She saw her GP at 34 weeks complaining of upper abdominal pain, but of dyspepsia type complaints. There's no record. The GP couldn't actually remember if the blood pressure, urine were taken. They were not recorded in the notes. We have to assume that they weren't. She was given an antacid, and she was found home fitting the next evening by a partner when he came home from work. She was brought in by ambulance. She was stabilised and delivered, but unfortunately the baby was stillborn. She ended up going to ICU. She had, when she was well enough, she had a CT scan that showed that she had had a CVA, she'd had a stroke. And when she awoke with her hemiplegia, she was told that she had no baby. So this is what can happen. Looking quite well, bit of discomfort, next minute she's at death's door and she's lost her baby. So again, I don't want to cause fear, but it is really important. If you take away nothing else, somebody's getting a bit of blood pressure, a bit of protein, we have to be sure. So Sharon is going to come. You're going to hear my talk after. Sharon, she's going to talk about the diagnosis, what is proteinuria, what is blood pressure. She'll come back, so apologise if I sort of go over that briefly. But what I really want to cover is, in the antenatal care scenario, can we actually try and prevent preeclampsia? How should antenatal care be given to women who are hypertensive or at risk of preeclampsia? And then how should we monitor these women throughout the pregnancy and their babies when they're at risk? And what do we do when they're admitted? How do we plan to investigate them? How do we treat them? And when is the best time to deliver? Because that is so important for both the mother and the baby, getting that timing right. One of my friends is an orthopaedic surgeon, said obstetrics was easy. You'd only one thing really to do, when to plan, when to deliver. So that's my job, to decide when's the safest time for the mum baby to deliver. And intrapartum care, again, how do we deliver that woman? What do we give her in labour? How do we monitor the fetus? And then just also about eclampsia, the management of eclampsia. So there's an awful lot to cram in, so please try and bear with me. The definitions, again, Louisa said these right, but chronic hypertension, again, this is somebody who presents at booking who's hypertensive. She does not have proteinuria. Occasionally we'll get somebody with renal disease who might have that, but we'll not get into that. But chronic hypertension, booking at 20 weeks, before 20 weeks or seen at 20 weeks with high blood pressure. Gestational hypertension, non-proteinuric high blood pressure, that develops in pregnancy. Preeclampsia, blood pressure and proteinuria. And if somebody develops that in pregnancy, blood pressure, significant blood pressure, significant proteinuria, they've preeclampsia until proven otherwise, and you should treat them like that. So I'll not go into the details again. Louis or Sharon will go through the details of the blood pressure and urine. The prevention of preeclampsia. I think Elaine is absolutely right. When we are looking at our stillbirths, the risk management at booking is absolutely crucial. And that will often be in the midwife's arena to really decide, is this woman, I don't like these terms, but high risk or low risk pregnancy, what is her risk? And definitely if we do feel that, and I can say that I'm in obstetrics 22 years and we do not, and I hope you're the same in your units, we do not see as many women really ill in the intensive care setting as we used to. And I think that is because of better risk management and better management of these women when they're admitted and delivered. So we know that the risk will be lessened if there's good prenatal counselling for these women. And actually, if you can get somebody who's at high risk, who's had a bad pregnancy before complicated by preeclampsia, or they're hypertensive, renal disease, etc., if you can see them, maximise, it's a bit like diabetics, if you can see them before, maximise their chances of having successful pregnancy, all the better. So reduce their hypertension, maximise the treatment of their other concurrent medical conditions, lose weight, low salt diet, all these general things. And these are the things we can do when we're seeing these women postnatally as well. Moderate exercise, put them onto the safest medication, avoid ACE inhibitors. and keep the blood pressure lower than 150 and 100. I mean, ideally less than 140 over 90. And get them to lose weight. I think that's a very, very, very important point. So aspirin, there have been some big meta or systematic reviews, meta-analysis again suggesting that preeclampsia can be reduced. We tend to use baby aspirin. Some of the newer trials are looking at 150 milligrams of aspirin. And the risks for preeclampsia, again, hypertension, either alone or during a previous pregnancy, chronic kidney disease, autoimmune diseases, particularly lupus and antiphospholipid syndrome, diabetic women, people in their first pregnancy, age 40 years or older. Again, a prolonged pregnancy. And I saw a Polish woman who's 12 years since her last pregnancy, same partner, but the body will probably treat that as if it's her first pregnancy, a large BMI, and of course multiple pregnancies. So the guidelines now, the Irish guidelines, which I've used for stroke, and the NICE guidelines, would say that yes, aspirin given before or around 12 weeks in pregnancy until about 37, 38 weeks can reduce preeclampsia and about 20% of hormone. Now, this is where there's controversy. These are guidelines. Some of these guidelines are evidence-based guidelines. And that would say that a lot of things I think Elaine was talking about, there is no evidence for those. So if you have somebody coming along to you and saying, I'm using garlic and I'm using this, you can say there's no evidence it will work. And I think you could say it's probably not going to do any harm. She might lose a few friends if she's eating a lot of garlic, but otherwise it's going to be okay. But again, I think sometimes if people are talking about things that are untried and you think, is that a bit dubious or dangerous? Be very honest with them and say, there's no evidence, it might not be safe, so leave it. So what is severe preeclampsia? Why do we get worried? I mean, we've talked about that girl lying in intensive care, but what is it when somebody says you've got severe preeclampsia? Well, it can be preeclampsia. It doesn't have to be somebody whose blood pressure is through the roof. All of us who've been around a while have seen somebody lying in the ward, a bit of mild hypertension, and the next thing she's fitting or she's very unwell or the CTG goes right off. So preeclampsia, with the symptoms or signs that will herald an eclamptic fit. So somebody who's got a blinding headache, she's feeling shaky, jittery. Sometimes you touch these women, you can really start to see the whole body start to fit. That's a very worrying sign. They've got biochemical blood investigations that suggest the multi-system disease is starting to really hit. Damage or death to the baby, of course, can be a real worry that everything's becoming very severe. And the only cure for preeclampsia is to get that placenta out, to get the source of that toxin, whatever that elusive thing may be. We need to deliver that and deliver the baby. So, and there's also a rule of thirds, and sometimes I'll say deliver the baby in my future, but remember a lot of preeclampsia and eclampsia occurs postnatally. A bit like Elaine was saying, the lady wheeled from labour ward becomes very unwell. So we usually talk about the rule of thirds. A third will occur antenatally, a third intrapartum, a third postnatally. It's just rough and ready, but just to make us remember. And why does it matter to control your blood pressure? Well, the mean arterial pressure is that which keeps your blood vessels operating in the maximum, that they are beautifully perfusing your tissues. If your blood pressure is too low, you're going to get hypoperfused, the cells are going to become necrotic and there's going to be hypoxia. But if the blood pressure is too high, and that means the mean arterial pressure is greater than 125 millimetres of mercury. I've got a little diagram below just saying, I don't know if you've all known, and I'm sure you do know when you're training how to diagnose that. But if that is too high, your arteries become under far too much pressure. They're going to become damaged. You're going to get vasospasm, so your blood pressure is going to go up. And again, your tissues become underperfused. But the vessels can also leak as well, so you can get that bleeding as well. So not only can you get hypoxic-related stroke, for example, or liver or renal damage, but you can also get leakage and bleeding. So that's why controlling that blood pressure is so important. And really the principles of our management really ensure that the blood pressure is kept less than 150/100. I would be keener about 140/90, but in the management of the guidelines it says less than 150/100, and you don't want to drop it too low because the opposite is that you will actually underperfuse then the placenta. You need to watch for the abnormal haematological investigations, observe that woman for development of preeclampsia if she's hypertensive or severe preeclampsia, prevent an eclamptic fit. And also these women, they have leaky vessels. One of the things that happens in this multi-system disorder is these vessels are damaged by this toxin, and that's why you get edema, because the intravascular fluids start to leak out into the periphery. So if you start giving more fluids, you're going to make her more unwell. And of course, when we always talk about obstetric things, what about the fetus? So we want to monitor the fetal growth, make sure the baby's growing. And also we want to try and deliver that baby in the optimal... Can you hear me at the back? My voice isn't very loud, can you hear me? We want to optimise the birth of that baby if it's going to come prematurely by having time to give steroids properly. And also now, I'm sure many of you in your units are using magnesium sulphate. Now we like to give that not just for blood pressure, but optimise, give neuroprotection to the baby. They do better, the brains do better if there's magnesium sulphate on board. And we want to prevent abruption because of the blood pressure is really high. And there's severe preeclampsia, there's placental abruption. So antenatal care. Women with chronic and gestational hypertension do go on. 25% roughly, both groups will get preeclampsia, and 50% of women with gestational, or 50% of the women that get sort of early onset preeclampsia also have gestational hypertension before, so they need to just watch very carefully, these group of women. If you've mild to moderate hypertension in pregnancy, you don't need admitted to hospital. That's one was Lane saying the obstetrician can sit on their hands but devise a plan. And they should be seen weekly or twice weekly for blood pressure monitoring in a DOU or with their midwife. And at that, there should be blood pressure monitoring and there should also be analysis of the protein. So I'm sure it frustrates you. People come to their meetings and they don't have their urine sample. They should have their urine sample, and it's important you get them to go and give that urine sample and you test it properly. And you should treat moderate and severe hypertension because even if they're non-proteinuric, if the blood pressure is getting high, it's damaging that woman's end organs and it's also damaging the placenta and potentially affecting the baby. And blood investigations, they should really only be done, I think, if you have moderate hypertension, really at the initial diagnosis. You don't need to keep repeating it. And the women with sort of moderate blood pressure that you're sort of controlling with medication, you don't need to keep taking bloods from her unless she's deteriorating. And monthly fetal dose scans are really essential. The new NICE guidelines in IUGR in the UK, and I know there's ones come out recently from the HSE, say that you should really scan these babies every month from about 28 weeks, maybe earlier, depending on their past history. Timing of delivery, I'll come back to this a little bit later in the delivery section, but timing of delivery, you heard Louise saying women who've mild or moderate and treatable hypertension, because I think we forget about that. You know, you forget that this woman is actually being treated. She's on the beetle and she's coming to see you and her blood pressure's sitting about 138 and you think everything's fine, but actually she's not normal. So again, this is where I think we have to say, and I see this in the unit and I see this in, I work in, that people forget this isn't normal, this is a high-risk woman. And there is evidence now that, as Louise said, you should actually offer induction to these women around 37 weeks. I'll come back to it. But it really doesn't matter. I haven't gone into the clinical treatment here in terms of is this early onset preeclampsia, is it late onset? If there's problems, you need to deliver. It doesn't really matter what gestation it is. You've got to try and save the mother's life because she will die if you don't, or she'll be very damaged if you don't get things properly right if she's got severe preeclampsia. So if she's got severe untreatable hypertension or there's severe fetal concerns, you deliver her. So mild hypertension, moderate hypertension, severe hypertension and preeclampsia. Just a little bit of a summary there. If you've mild hypertension, do you treat her blood pressure? No. You don't need to treat her blood pressure. Do you admit her? No. But you keep monitoring her. If you've got moderate hypertension, 150 to 159, 100 to 109 millimetres of mercury, do you treat her blood pressure? Yes. But you don't need to admit her. If she's got severe hypertension, this is non-proteinuric hypertension, do you admit her? Yes, you do, and you treat her as well. Okay. If she's got preeclampsia, it doesn't matter if it's mild, moderate, or severe. If she's got proteinuric, confirmed significant proteinuria and blood pressure, you admit her. And this is, I don't know how you're finding things. The recession, both north and south, has led to bed shortages. And people are under pressure, and this is a big thing, I think, for APEC, that there seems to have got this kind of, it's just a bit of mild blood pressure. That is a really wrong attitude, because believe me, in my role, seeing it is happening, these women are coming back unwell. If she has got proteinuric hypertension, you admit her and you investigate. Now, she might not have preeclampsia because she might have a urine infection, a bit of blood pressure that seems to settle, but you must admit her until you find out otherwise. There's new treatments coming back. Louise will talk about those later. They're in the research field. This is what you must do at this moment in time. This is what NICE and the Irish guidelines say. So you admit to hospital, just to summarise, non-proteinuric hypertension when it is severe, Okay, so you need to treat that and make sure she's okay, and all pre-eclampsia. So what are the symptoms? And I think this is, again, a big role of the midwife. I think, again, this is one of the things we should be saying, when we're seeing people at visits. And I do try to say this to people when I'm seeing them, later in pregnancy. These are the things you need to be worried about now. You get any of these signs, along with things like fetal movements and how to monitor them. Severe headache, visual problems, and women often complain of like a blurring, little black dots or flashes, which is due to retinal ischemia. Severe pain, particularly just below the ribs, and they can get sometimes like a gastritis type thing because they've got edema of their stomach. You can also get swelling around their liver capsules. So again, that was that poor lady that had the stroke that I showed you. She complained of just some pain here. Vomiting. Sudden swelling, and I think that, we're asking about swelling earlier on. I think that sudden swelling is a worrying sign of her hands, face and feet. And I also advise them about decreased fetal movements, because remember, we're not just thinking about the mum, we're also thinking about her baby. And the two often go hand in hand. So she'd know if she's got decreased fetal movements and how to monitor them to come in. So with pre-eclampsia, what do we do? Well, you admit, you control her blood pressure, and you should measure at least 4 times during a day on the ward. You should use the Midwifery early warning score. Just hands up, who uses these in their units now? It's almost 100%. Is that lifesavers? We'll talk about it later. They are fantastic. Made my job so much easier over the years. You can see everything beautifully, pictorially in one place. Biggest thing I think since really we could just really look through at the labour, and I just find that absolutely marvellous. So we don't need to keep quantifying proteinuria. It doesn't really make a huge amount of difference. We can dipstick it on the ward, but you don't need to keep standing it off for 24-hour collections or PCRs. Obviously, if she's gone from plus proteinuria to 4 pluses in the clinical scenario, you're thinking this is significant. You don't need to keep quantifying it. It doesn't really make a huge difference. Keep an input-output chart, because, again, anuria could show renal disorder, very important, renal damage. And you really monitor blood investigations. You find there's a bit of a tendency to either completely stab this woman to death and take her blood every day, or the ones that really need it don't get it. So I tend to say if a woman's fairly stable, you don't need to keep taking her bloods, but if something's starting to go wrong, her blood pressure's starting to really hit up, concerns fetal movement, she's feeling well, do her bloods, because she might be getting sort of imminent eclampsia. And remember to keep monitoring the baby. We'll come back again. You don't need to overdo this. Certainly if there's concerns about IUGR, it is very important. And remember thromboprophylaxis. These women are high risk. Not actually mentioned in NICE guidelines that I could see, but they are mentioned in the Irish guidelines. So that's so important, their risk of DVT, because of the damage to the blood vessels. So what about the antihypertensive treatment? Usually you try one drug, and then you keep going with others to really about a maximum of 3. That would be our sort of rule. And if one drug's not working terribly well or at the maximum limit, you don't stop it and then keep adding. That's dangerous. So you keep trying with your drugs, and that's true in labour as well. So the drugs I'm just going to talk about that we usually use, not in any particular order, but in our unit now, and I think in the NICE guidelines it really does recommend labetalol as first really the first option. So labetalol is usually first line, and the initial dose is about 100 milligrams. That's really to prevent the side effects, and I would usually increase that then, to the therapeutic dose 200 quite soon. As Louise was saying, the maximum effect's in a few hours, so we do tend to use it now more on a 6-hourly basis rather than twice a day. It does work, because often if you use it twice a day, you're going to need other medication in between. So the maintenance dose is usually about 200 to 400 twice a day or 4 times a day. Actually, the Irish guidelines suggest about double the dose that you can use safely, and I went with the BNF. They're both safe to use. The common side effects are nausea and dizziness, and you should avoid with asthma, and they come in these different preparations: 100, 200, 300. Methyl dopa, round for a very long time, about 70 or 80 years now, very safe in pregnancy, but it can cause sort of sedation and depression, especially if you're using the higher doses. So, if you've got somebody that's feeling a bit whacked out on there, maybe worth thinking of putting in another medication rather than keeping them going on methyl dopa. It's not the nicest drug to use, and certainly postnatally it should be stopped, but it is safe. You can use doses of 250 to 500 milligrams 4 to 6 times a day, but caution with hepatic disease. You may find sometimes people's liver function starting to go off. If it's not too high and the woman's otherwise well, it can sometimes be a methyl dopa or a labetalol effect, actually. And then Louise has already talked about nifedipine, commonly Adalat, we think of it. Nifedipine, again, safe in pregnancy. And I agree, the sort of slow-acting nifedipine is better because women often get really quite bad headaches with nifedipine. And again, we're talking on the ward scenario, or even the outpatient chronic hypertensive for these. They can cause problems. Nifedipine used in the critical situation, I'm quite cautious about. And again, it comes in 30, 60 or 90 milligram doses, up to a maximum of about 120 milligram. The blood tests, so we call these the Preeclampsia bloods, that sort of cover the bloods you commonly use. I'm sure you all use them. So full blood picture, really for looking for the platelets in particular. Liver function tests, particularly looking for elevated transaminases and liver swelling and damage. The urate, again, is a kind of marker for renal function, and urea and creatinine. I only order a coagulation screen if there's low platelets. If you're worried about low platelets or DIC, it's not worth doing this all the time. And when the woman is admitted with either severe hypertension or preeclampsia, so non-proteinuria, severe hypertension, you should, I think, do an initial fetal ultrasound of fetal growth, fluid, and umbilical artery Doppler, and that would certainly be what would be recommended. If the woman's quite stable, you don't need to keep scanning her. It should be every 2 weeks if she's very well, but they often, I don't know what your units are like, they usually come up our way about every week. I think if they're in this kind of that feeling, you should be scanning them, seeing how they're going. And again, I think if there's no problems with fetal growth and the woman is stable, you do not need to keep CTGing all the time. But if there is IUGR, you do, because that is important. And particularly if the woman is saying she feels decreased fetal movements, obviously that's important. Very importantly, the job of somebody like me is to write a very careful pathway in the notes that people feel that they can refer to. And the most important thing is when to deliver, really, this woman, how are we monitoring them, and when should we get suspicious, when should we start thinking about things like steroids, magnesium sulfate, and when should we deliver and what needs done. And the unit I'm in, unfortunately, again, we have a shortage of neonatal cots, and you need to think timely, and you sometimes need to think, you don't want to wait till the critical stage, till abruption, till the abnormal CTG. You want to be thinking, ahead. It doesn't always work that way. You do get the surprises. So we like to discuss it with our neonatologist, when would be a good time, when we get magnesium sulfate, we need to speak to our anaesthetist. And the other thing is, if we're going to transfer, we need to transfer safely. And what are the maternal factors that men make us think, oh my goodness, I think I need to deliver this woman with eclampsia? So obviously this woman's very unstable and she's going to be very unwell. Her blood pressure is uncontrollable. We cannot control her blood pressure with medication. She's not responding. It's not working quick enough. And moderate hypertension and severe headache, something that makes you think she's imminently eclamptic. I think I've gone through those epigastric pain, clonus. And her platelet count is falling, because we, again, Hellp Syndrome, elevated liver enzymes and low platelets. If her platelets are falling, obviously that's a worry, and it's just going to keep getting worse. If she's doing that, it's going to keep going. You don't want to leave the platelets so low that she's going to bleed to death during her delivery. And rising AST and ALT, and also her renal function, if you're very concerned that her renal markers are going off. From the fetal point of view, well, placental abruption, that's pretty obvious. An abnormal CTG, IUGR and early onset preeclampsia. If the baby's doing okay, if the mum's doing okay, you can wait till around 34 weeks. But after that, don't wait, because the outcomes are not good. So try and get that kind of early onset woman if she and the baby are stable to 34 weeks. You're doing great, I think, if you get them to that stage. And preempt that delivery. These are women, in my experience, where the baby will sometimes get sick quite quickly. So I would get the steroids on board quite early with these types of cases. And before 34 weeks, with the IUGR case, decreased fetal movements, there's an absent or reverse Doppler. Those are the times to get these babies out. And really, please remember the steroids. They are missed too often. And really, I go to sometimes, and some of my obstetric colleagues are agonising about giving steroids. When I worked 22 years ago, we used to give them every week. And I'm not being sued for the abnormal babies that are being born 22 weeks, 22 years ago. Now we tend to give them once or twice during pregnancy. They really make a difference. So please, if you're thinking about delivery, get them in. Mild to moderate hypertension and mild preeclampsia. So what about the woman that's sitting around the wards, or what about that woman that's come in with preeclampsia after 37 weeks? What are we going to do with her? We're going to sit around, we're going to induce her, what are we going to do? Well, Louise referred to the trial in the Netherlands. It's called the Hypertension trial, and it was looking at in mild to moderate hypertension, somebody even on outpatient management or somebody in with mild preeclampsia. Induction of labour after 37 weeks associated with reduction in the maternal, in adverse maternal and fetal outcomes. Or it didn't really make a huge difference in neonatal, but it really made a difference in the maternal outcomes, and also made no difference in the caesarean rates. So I think that is something people are very worked up about. Does it? No, it doesn't. Because again, if you push these women longer, they're going to get sicker maybe, and then you're going to be in a situation you have to do a caesarean section. So arranged delivery, if preeclampsia actually develops after 37 weeks, because this is a bit of an issue at your clinic and you admit somebody 39 weeks with preeclampsia and you're phoning labour ward and saying, can I try and get this woman induced? And they go, oh, we've nobody until the end of the week. Well, actually, the guidelines say you should really try and deliver that woman within 20 to 48 hours of diagnosis. So just worth, thinking about. So delivery suite management, okay. The basis of management: control her blood pressure, prevent her from fitting or control the fits, manage her fluid balance, and if she hasn't been delivered, get the baby out in a safe manner. Now, I'll not go through all the huge amount of complications there from the mother's side, but the type of the complications that she has will determine the level of care you need to give her in your unit as a midwife. It may not be actually even in the labour ward. So level 1 care, preeclampsia is mild to moderate or moderate hypertension. She can be managed pretty conservatively. Again, not suitable, as you'll see, the fetus needs very carefully monitored, needs one, not suitable for water birth, very low risk, but can be managed fairly straightforwardly, but watch carefully. Level 2, so when do you really need to up sort of to the HDU type care, which most of us can deliver on our labour wards, with our anaesthetist, or we need to transfer her somewhere where they can offer that type of care. And that I've given the list. Eclampsia, Hellp Syndrome, hemorrhage, hyperkalemia, renal problems, DIC. But we really need to think about level 3 or intensive care when we're worried about her just not stabilising and she needs ventilatory support. She really needs all the big guns going. In our unit, that means moving her across the road, but admittedly an ambulance journey. It's important with your anaesthetic colleagues to make that call quickly. And another big moot point, am I going to section or am I going to induce this one? And my feeling would be if you get your timing right, you can actually induce more than you section. And the maternal wish is obviously very important in all this, and the women helping sort of decide. And I think as well with the early onset cases, I think it's worth discussing whether things might go pretty quickly here, but we might be able to time things just right and, try and discuss what she would want as well. And things like gestation, so if you're 30 or 30-week prima gravida, it's unlikely that you're going to have a successful induction. But I've had quite a few people around the 34-week stage. It can be induced quite successfully. Cervical rightness is important. And also it depends just how unstable the condition is, because obviously if you've got those really severe things like eclampsia, HELP, deteriorating platelets, you don't have time sometimes to induce. Sometimes you do. In a power 3 lady with a 4 or 5 centimetre dilated cervix, you might get her baby delivered very quickly. But with a prima gravida in that situation, it's unlikely. So whatever you decide, make sure the mother is stable first. Because there can be that thing of, oh my goodness, fetal heart's abnormal. You can't just rush her to theatre. Again, I can think of 1 or 2 cases over the years where a woman's come in with a normal fetal heart, blood pressure is not too bad, and she's rushed to theatre without seeing what her blood indices are doing and has got very, very sick then. So the lovely Muse chart, number 1 thing, and we actually use that in our antenatal wards now as well. I think it's fantastic. And the women should be in a quiet, well-lit room. I think she should have one-to-one midwifery. All women should have one-to-one midwifery. And the consultant obstetrician should know and should be able to write a plan for her. When do we intervene? When do we stop? When do we decide we are going to do a caesarean section and not hang around? So these things are important. IV cannula in, and remember to give infusion pumps so you can carefully monitor your fluids. On the Muse chart, blood pressure should be done every 15 minutes initially if she's stable, half hourly. She should have a catheter, should be catheterised if you're using IVs. That would be my feeling, that because they can get fluid overloaded, and watch that output. And our women with certainly moderate severe preeclampsia will have O2 sats done, respiratory rates, temperature, And CVB and arterial lines for sick women, they should also be included on the news readings and have other charts too. And if you've got severe pre-eclampsia, you should also have a neurological assessment. So again, the bloods are more or less the same. We tend to repeat them in moderate or severe preeclampsia every 12 hours, more frequently if maybe the situation's deteriorating. You're trying to keep her there to give her mag sulf and steroids, but you're worried that her platelets maybe are falling. Do them maybe every 4 hours in that situation, because you might need to deliver her. And also group and save her. Group and save in case she does need a cesarean. She needs continuous fetal monitoring. She's got moderate severe preeclampsia. If she's in labour, really, with all preeclampsias. And ultrasound occasionally, again, that can be used, because some of these women will be there being stabilised for delivery. So sometimes you might need the ultrasound just to make sure she's not maybe bleeding or something like that. Would be one of the things we do. Keep that blood pressure low. And again, labetalol tends to be, in the guidelines, labetalol's really the first choice. And the good thing about that is you can give it orally. So people that are mild, sort of moderate preeclamptics, you can give that orally. If it's not working, you can give boluses, and you can use it in a syringe pump infusion. Again, it should be added into this sort of 80 mils an hour that we talk about. And if her blood pressure's not stabilising, it's still 160/105 after 1 hour, if you've tried everything, it's not working, move on. Don't keep banging her with more, just move on to the next, but keep it running. Again, that is a mistake people do. They just say, we'll stop it. The blood pressure flies again. The alternatives, if labetalol not working, and it's contraindicated in asthmatics, being a beta blocker, then use hydralazine. And again, you can use bolus doses. If you've still got your labetalol running, if you've used it, just keep it going, and usually boluses will settle it. Louise talked about nifedipine. I don't like using nifedipine generally because it can tend to drop the blood pressure, and you should never use it the way you do in the cardiac setting, bite it, bitten them under the tongue, because the blood pressure become hypertensive. You could cause problems for the mother and particularly the baby. And also, one of the things that is important about nifedipine is don't use it with mag sulf. So again, all those things make me think this is a real last resort if you have somebody that's really, you're just desperate. Magnesium sulfate, so severe preeclampsia. So somebody who's got severe preeclampsia and all those kind of complications I've talked about before. She's really not settling, she's deteriorating, she's got Hellp Syndrome, abnormal bloods. And it's the first line of choice. And do not use diazepam or phenytoin instead of that. The eclampsia trials show that that is the drug of choice. That should be used first. And you give a loading dose of 4 grams. Do you all have like an eclampsia box in your units? And it's so vital. Those are great. It's just made such a difference. Everything's there. Bring it in. 4 grams. Give it slowly over a few minutes, and then get your infusion going. If they're still fitting, then you can treat them with further magnesium sulfate. The only times I can think of that not working and they keep fitting, there's something else going on. They're bleeding, or the cause of their fits is not eclampsia. It could be epilepsy or something else. So, of course, magnesium sulfate, it's a nerve depressant. So that means that you can get motor paralysis if you use too much, and that can be shown by absent tendon reflexes. And of course, the woman's breathing can really go down, so we have to watch your respiratory rate very carefully. So pulse oximetry is essential if you're using it. You need to watch your output as well, because if you're not excreting enough, then it could build up and be dangerous and toxic. And you should do tendon reflexes around some places do it every hour. So stop it if your reflexes are absent, and also if the respiratory rate's less than 12. And if you're really worried about respiratory arrest, because that, I've never seen it yet, but we've certainly seen people with some of the other signs. The antidote is calcium gluconate, and that should be in your eclampsia box, ready to give. So fluids. So we've talked about overload and pulmonary edema. The guidelines all suggest that the golden amount is 80 mils per hour. Just keeps her going, keeps her perfused, but it hopefully won't cause fluid overload and pulmonary edema. And again, remember that when you're using syntocinon, if you're inducing somebody who need that in labour, use it if you can at high concentrations with the syringe pump. And oliguria. Again, if somebody's oliguric, you don't keep loading those fluids. Generally, just watch and wait and see. It may precipitate. So I think that says may precipitate delivery. So again, if somebody's not peeing, you might think, I can't really wait another 10 hours, so let's get the baby out. And that's what we don't want to see. Really increased vascularity, fuzzy diaphragm. That is pulmonary edema. And really, that would be the only time I would say that you use diuretics. So again, we used to use those more. That would be the only time if you think you've overloaded somebody. Don't forget again about thromboprophylaxis, because these women, again, can get clots, and they're the ones postnatally can get clots. TED stockings, Flutrons, intravenous heparin to those extremely high risk, some of those autoimmune people. And post-delivery, just be careful again, but do start their heparin. Again, you should have guidelines in your unit about when to start after spinals. So what about the second stage? Do you need to get your obstetrician in doing a forceps? Well, not necessarily, not really. If her blood pressure is controlled, if she's doing well, then I think she can go ahead and, she can have second stage as normal. But obviously you're going to call them if the CTG is not good. And remember, these placentas can be damaged. So again, if you're seeing a nasty old trace, it's because maybe this baby's got a grotty old placenta, it's just not coping well. So again, get the baby out quick if you think the CTG is not looking too good. Third stage, again, really important, do not give symptometrin in somebody with hypertension. Definite cases in the maternal mortality reports of stroke. So that's one of the big things. Okay. I couldn't get this video to work, but I think I might have cried. Did anybody see this? Just sitting watching on the TV. This just occurred, and I actually got really quite emotional and thought, we are so blessed to practice in a first world country when we can hopefully avoid this thing. And there's nothing they could do. The thing wasn't this in the 20s in Downton Abbey, Lady Sybil has pre-eclampsia. They keep dithering whether to deliver a baby again. Caesarean isn't an option. And she has a massive eclamptic fit and dies. I think the baby was out actually. She had a postnatal fit. It was just horrific to watch. So it happens. I don't think that it's happening as much, but it can happen, and we need to know how to deal with it. So first thing, get everybody you can to help. Senior midwife, other midwives to be runners, junior, senior anaesthetist, and junior and senior obstetrician. Remember your sort of ABCs, give oxygen, roll her onto her left lateral position, if she's pre-delivery. Get IV access and bloods and give the magnesium sulfate. And again, give that bolus dose of 2 grams and then infusion. If she's still fitting, despite that, think outside the box. Think maybe, is there something else going on? You might consider diazepam. You might need to ventilate her and get her to ICU quickly. And you think you need to really consider investigations such as CT for other causes when she's stabilised. So really do think about neurological causes. Could there be a metabolic? Could she have diabetic ketoacidosis? Could she have, space-occupying lesion? Could she have sickle cell? Could it be drug-related? All those things, if she's not stabilising quickly. And get the medics. I mean, there's only so much I can do. Keep within your remit. Get other people to help you if you're not sure. You could save her life. And I worked in Bristol when they set up the prompt training there. I think it's great, and I still I really enjoy being a trainer, and I also kept being moved around the drills because we don't see these emergencies that commonly, but when they happen, and you really need that team working, I think they've really helped me so much, and certainly they're evidence-based now. Do you all have prompt training or some drills in your units? Yeah, they're really so worth going on. So what about transfer? Because this is important. When do you transfer? But you must ensure she's stable. You must make sure the right things. If she might need to go ventilated. She needs her blood pressure stabilised as much as possible. It's important the right people go. If that's a very experienced midwife and obstetrician, so be it. And all investigations have been performed, and hopefully they can go quickly to the other unit when she arrives. And also think about that baby. Steroids been given, even started one dose. It might do something. And magnesium sulfate. The anaesthetic considerations, again, just one of the most important things that everybody thinks about automatically. For example, with an epidural, spinal epidurals are very much considered. Epidural, and if theatre spinal epidurals are considered for the slow, can cause some vasodilatation and reduce the blood pressure. So the anaesthetists, we obviously quite like them in people with preeclampsia. But again, automatic, we often preload fluids. Don't do it in this situation. And avoid general anaesthesia, because these women often, again in the past, that was the big problems with these women going for caesarean section. They'd often get uncontrollable blood pressure, induction of general anaesthesia, and there could be problems intubating with laryngeal edema. And again, I think particularly for the midwives, when you're removing an epidural, sometimes it can be that rebound hypertension that might need acted on, might need more therapy. So arterial and CVP lines, I don't know much about these. These are the difficult, tricky things the anaesthetists do when women are sick. But basically what they're trying to do is just give you a much better idea about the blood pressure centrally, about the risk of fluid overload, especially when you've got a woman with lots of medications and you're trying to get that balance as strict as possible. So if a woman's unstable, her blood pressure's high, uncontrollable, also in very obese women, we are seeing them being used now, and particularly that sort of morbidly obese women, when really can't rely on the usual kind of methods of measure blood pressure, etc. And also one of the big things we all dread is the severely preeclamptic woman who then has a big bleed. That just makes life so much more difficult for her and for us just trying to get everything right. So they need obviously carefully charted as well, and the anaesthetist closely involved. So postpartum, again, it's important to watch your fluid management, and I think not panic. I think in the past, I think that's what did happen. We were talking about the decreased death from pulmonary edema. When I started in about the early 90s, we used to get obsessed about how much urine women would pass and giving her diuretics and giving her fluids and that kind of thing. And now the feeling is, don't panic, wait for about 36 to 48 hours. The vast majority of women will end up having a good diuresis. Again, beware of a pulmonary edema if they're really not passing urine, and it may be that they've perhaps damaged the kidneys. There will be some women that will have renal infarction and renal necrosis, so they will have some degree of renal failure. Rare, but can happen. Hellp Syndrome, again, can be particularly nasty on labour ward, because if they're bleeding, if their platelets are really falling, we need to be thinking of things. Generally, we don't have platelets around or give them if the platelets are more than 50,000. But if she's bleeding or her platelets are less than 20,000 and we're going to electively deliver her, we should have them. Steroids are very controversial for Hellp Syndrome. Actually, the NICE guidelines say don't give them, no evidence. And the Irish guidelines say do give dexamethasone. So I'll leave that maybe for further discussion. So we're going to have a talk later on postnatal care, but just immediately, and again I think that's important, the push for beds, getting people out, get them home. The guidelines, the Irish guidelines say, and I think this is good sage advice, send them home too early, they'll be back, because their blood pressure's high in the community, they get sick. So they should be kept in, it says here, till the third postnatal day, keep them in until their blood pressure is stable and you've got it consistently less than 150, 100. I think that would be good sage advice. And she probably may need to stay that in the full 6 weeks. She needs followed up in the community. She needs followed up in the hospital at 8 weeks. And she should have 4 hourly blood pressure measurements, afterwards on the ward, because she is somebody who can get sick. And I think it's important that she knows the signs. Again, you're saying to her, if you go to the ward, the midwives are so busy running everything else, these are the things to look for, call us and monitor her output. So sorry, a huge amount of stuff, sorry, it's a lot to think about. But the big take-home messages are preeclampsia can be lethal, and severe hypertension and not just proteinuric severe hypertension itself and preeclampsia may be lethal for mother and baby. You admit women who have severe hypertension and you admit women with preeclampsia, and you treat women with moderate or severe hypertension to control their blood pressure, and you will deliver if that woman has life-threatening complications, no matter what gestation. And just remember, these are the maxims, I think: control her blood pressure, control or prevent her fitting, monitor her fluid balance, and make sure she's stable before you get the baby out. So, it was supposed to be just before lunch. I'm sure you would all like your lunch, but I think there's another talk. And if you would like to learn more, the NICE guidelines, and also, as I found, lovely guidelines again, particularly intrapartum, are excellent, from the HSE and the Institute of Obstetricians and Gynecologists. They're all available on Google. Thanks very much.